Okay, great. Well, thank you very much for this opportunity to share some of the work that we've been doing in the postnatal patient safety learning lab. And I'm so happy to be here with my friend and colleague, Dr. Amelia Gibson. And so we've got some information from interviews that we've conducted with birthing parents around safety and trust and, how to have higher quality care from their perspectives and how we would know that. So I think that this intersects with, our fourth trimester tools and the initiatives that you all are doing, and just want to explore any synergy to inform each other. Okay, so this is us, and you all see me as a member of the fourth trimester project, and I'm a medical anthropologist. And Amelia, do you want to introduce yourself?
Sure. I'm Amelia Gibson. I'm an associate professor at the School of Information and Library Science at UNC. So I do research on health informatics, health information behavior, issues of trust and safety and marginalization, and how they occur in institutions and in community settings. So that's me.
And so we're part of a interdisciplinary team, and what's been so rewarding and I think helpful for moving these maternal health conversations forwards is really learning from each other and getting towards transdisciplinary thinking. We shape each other in the process and the questions we ask and the ways that we interpret it. And so we strive to truly embody, a learning lab. Then Amelia, can you talk about how we approach this?
Sure. So this is kind of my standard disclaimer, because I find that I'm usually the outsider in most of the teams. And a lot of times, because what I do is like system analysis and this multi-level analysis that goes down to the interpersonal level, what ends up happening when you talk about sort of systemic issues is that people can sometimes feel like we're talking personally about them. And so what I want to emphasize here is that we are focusing on the system and how systems create conditions for care, and looking at how those are good and also bad, right? And so I'm not sure if you've heard the phrase impacts over intent, but this is sort of where we're going here, right? We acknowledge that there are also systemic issues. There are lots of systemic issues that make improvement of some of these things very difficult. So again, that's not to place blame on people who are at the end, sort of like the end of all these like deep systemic issues, but we are going to talk about what those issues are. And so I just wanted to sort of put us in that mind frame before we have the discussion. Some good and some bad.
Yeah, so we'll be sharing, some quotes and some different things that came up when we asked about their experiences. And then I think that's what grounds us. And then we try to change at multiple levels to achieve that safety and whole person care that is necessary. And safety is, and we'll get into this, but, it's physical things, and it's also downstream effects, including with mental health. So this work is funded by the Agency for Healthcare Research and Quality. It's the mechanism is called a learning lab, patient safety learning lab, and it's been so fun to explore this. And so our team spans UNC, North Carolina State University, with their College of Design. And so we have multiple industrial designers on the team, and they really lead with like information hierarchy and, comprehension and accessibility. It isn't just about making materials, for example, not just drafting them and have the content and then having the format be appropriate, but really thinking about how things are used and integrated. So that's in what level of detail and things. The other PI, along with Allison Stubbe, is Emily Patterson at Ohio State, and she's a systems engineer. And so really thinking about what they call human factors, which is like how people use things and how it feels to be in that setting. So we're trying to combine forces to think together and to learn how we can strengthen what's working and address the gaps in care. And so we are focused around in the early postpartum period. So from floor status through the transition home and looking at things like acute care utilization. So OB triage, emergency department, and readmittance over the, through the fourth trimester. And so we do a lot of focus on inpatient because, and this is all as part of a continuum, of course, but we really want to be equipping families to be discharged and to be prepared and to know who to contact and have their appointments set up and clear and have appropriate framing of the value and importance of those and the worthiness of attendance. So that they not only are okay, but so hopefully we can set them up to thrive during this period. And this is, a very, the project ultimately is trying to address both maternal and infant mortality. And we do that by focusing on process. Process drives outcomes. Okay. And so, we approach this thinking about their priorities and what do families need most during this precious part of their journeys, which is impactful in so many ways. And this is just a cute image from a first grader. I went and talked about, the things that I do and asked them to share, like, what does a new family look like? And what do families with a baby need most? And I will decipher this. I think that it says food, care, teaching, milky, diapers, and lots of love. And I think that that's spot on. And that's what we try to do when we think about social determinants and when we think about feeling seen, heard, and loved. And we think about information exchange and also the supplies that people need. So I think that this embodies what we're striving for. And so again, we want to strengthen systems to make it easy to provide these in a sustainable way. So we have, big scope. We like to be ambitious like you all and trying to transform the system. So in AIM 1, we've been learning and trying to understand context in every way from birthing parent, partner, and healthcare team perspectives. And so we're just going to highlight some of the interview data from birthing parents, but we have a lot of other things to share, including we've done inpatient filming of people's stays. And so you can see stories, and we're like working on, co-developing solutions right now. And part of it is really communicating how things feel, and then perhaps showing how we can choose our own adventure. Like we can intervene at key points and that can change trajectories. So love to, continue this conversation after today. And so this is our aim too, is to provide some tools for addressing the gaps. So priority areas from birthing parent perspectives and also from clinicians, for example, for safe staffing levels. And so some of those things are sort of outside of the scope of what we can create, but we certainly are speaking to that with healthcare leadership and learning again about the values that drive the structures that are in place what we think is adequate and appropriate. So we're doing a lot of cool stuff with prototyping. And Amelia, do you want, I can shift and you can share your screen. I see the formatting got messed up on my Mac.
Yeah, that's fine.
I'll make you host. Okay, thanks.
I want to move the screen forward.
Okay, so yeah, you can advance. I just wanted to put this in context that we've been learning a lot and then trying very hard to have meaningful action around the things that have been shared with us. And so now we just want to share some of what we heard around safety in the postpartum period. And I know that our collective work through this project is around, outpatient care, but how people come into this and how we prenatal and, how they come into it postpartum and how we equip them prenatally is important. And so in the last few months during COVID, we did telephone interviews with 46 birthing parents and audio recorded those, and they were about an hour long each, and then professionally transcribed those. And in all of our data collection, we very intentionally oversample women of color. And so we've got a substantial proportion of moms who were Hispanic and also Black moms. And it's not on here, but most of our Hispanic moms were Spanish speaking, and we had a native Spanish speaker interview them. So what we pulled out for today, we asked a lot of things, but just about like safety and then demonstrations of respectful care, in this case, like what people do to trust and distrust. And so Amelia is going to talk about how that's operationalized. And so a few of the themes that we pulled out for today, resilience, major life event. This is, a big deal. And that's important to just be reminded of because then it's then also people's jobs and making sure that we know just how much we remember how it felt is important. And going to highlight some communication around these issues. Okay, so on these next few slides, we've got like the big theme up at the top, and then sort of an illustrative quote to show a little bit insight into what we see around this. And so giving birth lately has been a lot. Parenthood is always a lot, but now there has been so much more uncertainty. And so people always have goals and a vision for how they'd like it to go, but things are really rapidly changing and confusing. And so a lot of people, they're like, oh, I wish it could have been, this way, but they understand and they are flexible and, amazingly strong in navigating it through this additional layer of COVID and also racial injustice. And so birth is changes everything. And so this major life event, then, so people had, a lot of joy, and I want to make sure to elevate that. But then also, there was some sadness and anxiety because of the circumstances. And I think it's really important to validate that and to appropriately then enable people to be like, yes, people get it, and then move forward together. So with the sadness, people wanted their families, and with the COVID, protections, then people had to choose between, do I want my mom with me or my husband? And that is not easy conversations and caused some strain. And so they were sad about needing to have it be so limited. And it was anxiety inducing too, with especially when people paid for doulas and when they're not yet very accessible and covered, and then they weren't able to have that support that they had, expected and wanted. So people were coming into this not really ready, or it wasn't in the way that they hoped and desired. And this is something that we've talked about together in this collaboration about the importance of partners or other key supports. So companions were the world to people. And this is an image from our filming, and we've de-identified, the mom and the dad and the clinician who's providing some inpatient education, and she's holding the baby on her lap. So people, they need someone in their corner, someone who understands them and can be with them. And so actively including the companion is a safety issue. And then giving birth is often isolating in our society with our individualistic nature, but it was also even more so with the someone said the restrictions have been very restrictive. So these things are in place to protect people, and also makes it harder. So this mom was sharing how things were different because of COVID, and she could only have her husband there with her instead of the additional supports that she desired. And then also, once he was there, the policy was that, as they understood it anyway, is that he couldn't leave to get anything or to receive anything. And then we've heard in lots of ways, and I won't go into depth about it right now, but people need food. The kids know that. It's part of a very basic human need, and not everyone is receiving that. And so in prenatal care, it's a priority that people have some level of familiarity with the hospital system so that they know what their rights are and what's available to them, including access to food. And if you don't speak English, and if the requesting line is only in English for either part of the day or the whole day, it's a major problem that we've repeatedly encountered. People haven't eaten for 24 hours, and sometimes people don't know where to go, or they can't go to get it themselves. And so people are telling us, I can't make milk because I haven't eaten, and I need to get out of here because it's, we're pretty far, not only from a place of wellness, but sometimes it's described in very harsh sort of imprisonment terms. Okay. And then we're getting close to wrapping up my part, but just to elevate, communication is challenging. It's like the core part of any team, including healthcare team with the patient and family. And then when you also have a mask on, that makes it all that much harder. And so cues. So first of all, being limited with your ability to, like, how you can engage. And then when you come in, this person was just describing how it's hard to read social cues. And there's a lot of, hierarchy in medicine and power differences. And Amelia will probably expand on this, but this is a system that can hurt people, right? You can have your baby taken away, or the threat of that, or, these are people who very often save your lives. And so communication around these really critical events and processes is important. And so, when we have additional barriers like mass, then thinking about what tools we have. And so then that means verbal communication is even more not enough. You have to have like redundancy in the system so that people can actually comprehend what is being shared. Because going through warning signs in 2 minutes, right when they're walking out the door with the baby crying and their ride circulating, is not enough, is not meaningful. Yeah, thanks. And then, this is a pretty clear example of differences, and there differential experiences based on differential information and support, coming into birth. And so when there are policies that are, or recommendations, right, and things are voluntary, like who has agency in those decisions and who thinks that that is what they have to do. And so actually this quote was from a clinician, from an outpatient clinician, I think a home visiting nurse. And this person was saying, it's hard to know where the disconnect is with the different rates of rooming in with Latina families versus not. And there was a lot more separation with Latina families within the hospital. And so it's hard to know what the disconnect is. What we see is the result, which is a disproportionate number of Spanish-speaking families being separated. So it's hard to know where the break in the system is. And it's probably safe to assume that those conversations maybe didn't quite go the same way as they would for an English-speaking family, or in a conversation where there doesn't need to be interpretation. So maybe recommendations are framed in a way that it doesn't feel like a recommendation. And we could talk about this a lot, but there's substantial underutilization of interpretation services, and you miss also just the connection. And there's so much getting by with hand gestures and broken Spanish, and that's not appropriate. It's not legal or moral but when it's so hard to get interpreters there and the time, and when there's so much understaffing, then that's sort of the systems issues that we're talking about.
Kristen, this is Pam. Was this quote from the person specifically during COVID, or was it just in general? The whole idea of rooming in and the recommendations for COVID positive moms or people that were deemed at risk.
This is in the context of COVID.
Okay. I mean, our experience was that very rapidly our patients were hearing in their community that Atrium was taking babies away. That went through the community very, very quickly, that if you had a baby, they were going to make you put a mask on and they were going to take the baby away. So there was really no understanding about the agency or the autonomy of a mom to choose whether to room in or not room in. Immediately it was that you were going to be forced to be away from your baby. And so, I think that everything that you're saying is true. It's incredibly sad, but I also think that the caveat is that, we don't have, particularly in Charlotte, we just don't have enough Spanish speaking people in general. We just don't that are giving care. And so the idea that, one attending is there for, 20 laboring people, and to try to have the appropriate discussions that you have outlined that are so inadequate without another person interpreting, it's almost impossible to have a good outcome. It's almost impossible within the time constraints that we have.
And thank you. And I think that so when we recognize such stark and unjust parameters, but then how can we be helpful? And I think that, videos, like let's record the information. Let's also, lean into those, justified concerns, right? And like address them head on. We know that this has been heard. We know that healthcare institutions, like society in general, has done a lot of harm to families. Or I'm not saying this is what you'd actually have in your, but like, for sure, acknowledging, and then let's record it and have it be open access in advance and on the unit and on people's phone. I think that that's why New Mom Health and Salud Madre, among any other platforms, is just so useful. And we are, the Patient Safety Learning Lab, we are making videos for sure. Like, because I would also say written materials, and we know that access to technology, and so I think both, like very low literacy, and I think because then people can play it over and over and whenever they want, right? Like you need to hear things more than once. So I think, and we have a like slide, like things that we're excited about and things that we're doing. And I think you've probably said that in previous meetings, how we need videos in addition to any written material, and same with regular discharge teaching and all this stuff. You don't need that person to say the same thing over and over. What you need is to then like process it together and like what wasn't clear, what are you, and tailor it. But otherwise, all like the core stuff that should be provided before and in multiple accessible ways. We also need racially and language concordant healthcare teams, but that's a sort of higher policy. Okay, and so like proactive support. This is like where I jump off my chair. Like we need to know how it feels, and we need to structure our services and care around that, so people don't feel like they have to have their guard up or be watching or be vigilant against potential harm. And so this example is like when a clinician came in and put her stethoscope on the baby. And again, this is in the context of COVID. Like the mom didn't see the clinician clean it in front of her. And so then she had to wonder, and this is taking away from her, joy and recovery and healing and excitement, because like, is this going to maybe hurt us? And so do these things in front of them. So whether you wipe it or whether you just say, right, so that people have reassurance and peace of mind, so they're not wondering. Okay. And that example was a stethoscope, but like that point about people needing to be vigilant about things, I think is very generalizable. All right, I think this will be my last slide, and then I'll turn it over to Amelia. But so this is just a disaggregated visual of what the themes were with safety. I just shared some things like about communication and like bedside manner, but wanted to show how for a lot of the birthing parents who we interviewed, then they're in the middle, there's these core things that everyone said. And then when you look at, Black moms and white moms and Latina moms, then there are some, you can see overlapping, like the Hispanic and Black. Participants from those groups said about not feeling alone. It could be that the white moms are so privileged and don't have, they have someone there or whatever, that that wasn't like at the forefront of what they share. And privacy, I think that these are things that we could go into a lot more depth, but just to show how we have common and more specific aspects that are how they describe safety, not just what they would like, right? But this is essential.
Okay, so I'm realizing that one of my slides is missing, the one that just gives you an overview of safety. So I'm just going to tell you, I'm going to talk about the ways that moms defined and then operationalized safety. So theorist / practice, that's my thing, like theory to practice is my information, right? And so I was looking through the data for very specific like definition. So what we have here is like safety is a feeling, safety is actions, process, and behaviors. Safety is an outcome, so a state of being, and then safety is access to resources. And I'm only going to give one example of each because I knew that we wouldn't have enough time to go into all the details, right? When we talk about the most common theme is safety is knowledge and action. So people talking about safety procedures, when they were asked, what does safety mean to you? They start describing things that are done, right? So infection control, like washing your hands, the example of the mom who wanted to see the stethoscope cleaned, right? That kind of thing. But the most frequently mentioned one was this idea that safety meant keeping track of the baby's whereabouts, right? And knowing things. So knowing where the baby is, knowing that things are clean, knowing how to do things, right? So in this example, this person said, first, my baby, they checked the bracelet with his number and his name to make sure that he's a baby no one else can see. So there's that issue of control and agency. I was in intensive care for a day and a half, and they checked who the persons will be who will see the baby, and that was very important to me. Another frequent definition of safety was the feeling of not having to worry, right? So, this person said safety is the feeling that the baby's well, that everyone's taking care of her, and saying that sometimes as a mother you're not confident and you're afraid, basically, about your ability to take care of your baby. And I was afraid of my baby choking in the middle of the night or something like that. And I called the nurses and they came to check my baby, right? So confidence, the feeling that they were supported, that was an important one, the feeling that they had backup. And so those were frequent. Safety as access was another. So this person says safety in the postpartum period to me means feeling competent with my baby, right? So there's, again, that feeling of competence. But going forward, they say, aside from concrete safety, like I have a good home, I have plenty of food, we've got diapers, I got a wonderful husband, I don't worry about any of the basic needs. This was another sort of frequent definition of safety as like access to things. I also frame this, and again, some of this is interpretive, right? So I'm going to talk about framing that was sort of on the edge of our categories. Access to people was an issue, right? So like safety is knowing that I can get a hold of the doctor whenever I want to. Safety is knowing that I have diapers. Safety is knowing that I have, like, so there's things or people that you can have access to. And there are all sorts of ways that kind of ties into class and education that we could get into, but we won't because we have 15 minutes. And then finally, safety as a state of being. So safety as something you are because of all these other things happening, right? So safety is making sure the baby is healthy and that I'm healthy, like mentally, physically, and everything. And so I found here that when we looked through the data that this was sort of when all is said and done sort of assessment of safety. And I think this is where I hear folks on the clinical side talk about safety the most, right? So it's like, the person is safe, the mother, the baby, they are healthy, and that's how we talk about safety. Well, that's what I've heard people talking about safety as. The second question was, how did mothers define and operationalize trust? I found that safety and trust were very closely tied together, but I separated them because they weren't exactly the same, right? So I wanted to point out that, well, we'll just say trust was defined as expecting a particular behavior first, most, right? So they trust that someone will do something, for example. Then confidence in the provider or the patient's competence or ability to provide quality care. Trust as a feeling was another thing. I feel trust as a feeling and safety as a feeling were very closely tied together, right? Believing that the patient or the provider is telling the truth or being honest about things. The belief that the patient can act in their own or the baby's best interest, right? So this was also tied to this idea of like trust as freedom, right? So like they trust, the doctor trusts me, yes, because they let me go with my baby. They thought I could be safe with the baby. Then trust is being willing to share information. Compliance was a big thing that was sort of a red flag for me. So yes, they trust me because I do all the things that I'm supposed to do, right? And then depending on the provider for care. So of course I have to trust them. Vulnerability, the idea that trust means that you're giving yourself to a person and becoming vulnerable or accepting risk. Reasons for trusting, again, a lot of them are tied very closely to this idea of safety, but also to an idea of safety partially meaning agency, which is complicated, I think. One is that the healthcare team and the provider explained things willingly, that they listened, that they were receptive to their concerns. Frequent communication, checking in, right? So attention, basically. That they were engaging in what they felt was shared decision-making around their care. So like here again, they're attentive, that the sense that they were competent or knowledgeable, that they had a long-term relationship with this person. So even when they didn't agree with things, if there was a positive long-term relationship, they're more willing to trust, as in comply, or to kind of rely on their expertise. Here again, the sense of obligation to trust. So trust as something that's owed. We saw this a lot with Spanish-speaking participants who were almost defensive about the question of trust. So do you trust your doctor? Of course I do. I do everything they tell me because I'm a good patient, right? So I didn't put it in red, but that's one of my red flags there. Belief in professional training, or the idea that as someone who is a physician or someone who is a nurse or someone who's a midwife, you have a responsibility, and so that they could rely on that, right? So it's not that they know you, but that they trust your credentials, so credentialism, right? Another red flag here for me is resignation or perceived lack of choice. Well, yeah, I have to trust it because there are no others, right? So what else am I going to do? And then trust because of shared identity or language concordance, right? So quite a few people talked about being able to trust because someone speaks Spanish also, or because someone is the same race or ethnic group as them. Distrust was a thing also. It was a much weaker theme, so that's good. It wasn't that people were going around saying that they distrusted their providers, their doctors, or their midwives. Interesting to me is that a lot of the ways that distrust were operationalized were also present in the ways that trust were operationalized, right? So second guessing decisions as opposed to shared decision making. Ooh, I'm dropping things. Persistently asking questions, right? So the sense that they didn't get the information they wanted, so they would continue to ask questions. Disbelieving for the patients, the sense that their provider disbelieved their knowledge about their own bodies or health was a sense that's how they framed the feeling that they were not trusted by their doctors, right? So if I try to say something and my doctor doesn't believe me, I get the sense that they don't trust me, basically. That was their definition there. And then a feeling of worry. So like consistent low-level worry that the provider or the doctor or the midwife is not doing something right. And then reasons for distrust that were given was the perception that the team had caused physical pain or harm. Remembering that these are specific examples. So I say physical, that's not to say that this is the only thing that could exist, right? This is just what exists in the data. Disrespect, bias, or discrimination. The perception that they were not listened to, and then that they refused to communicate or explain things when they were asked, right? I mean, we can see that. So I say here on the left side, the distrust looks a lot like trust in some cases, because in some cases people said, a trusting relationship is one where I can go back and forth with my doctor and we can like talk about what I want to do, right? And so that could look like second guessing, that could look like persistently asking questions. So just take that with a grain of salt. One thing I want to point out is that the sense of safety is not necessarily the same definition that is used sort of widely on the institutional side, right? It was important for us to sort of examine this patient definition of safety out of sort of in an effort to, how do we say it? To ground our definitions in more of a reproductive justice framework where safety and rights are positive rights as opposed to just negative rights. It's not just not doing harm, but tell us what this means to you, right? And one of the things I found is that when people felt safe, according to these definitions that they had given, they were more willing to share information freely. So one of the questions we asked was about whether they share their full story with providers, why they share information, when they choose not to share. And most of them, a little over half, so that they felt fine or good sharing their information with their providers, but it was tied to the idea that they trusted their team and that they assumed that the information that they need that was requested of them was relevant or important, right? So that's something to keep in mind. And then only half said they shared the full story, whatever they considered to be the full story. So they sort of disclosing freely information. So that's something to think about as we talk about understanding parents, like birthing parents' own definitions of safety. And then I'm going to turn it back over to Kristen.
So this is our last slide to just facilitate conversation. So we say a lot, how might we re-engineer systems of care? And then sort of the big buckets in my mind, like we want family-centered care. And here's my proactive again about rights and resources. So one way to do that is like a service blueprint. So like I suggest like one page that people have during pregnancy printed out and also on a website, link for your phone, whatever, that says like things that what to expect. And so like you can expect this many visits, you have access to nutrition counseling, positive coping strategies, you have the right to meaningful communication, including with interpreters. And then it'd be great to have the flip side be a healthcare service blueprint so that they know the contact information for the financial resources and for the nutrition and for all these things, so that people don't learn about things in a haphazard way or too late. And next on here, so timely information exchange. And I think this is what unites us all in this specific project, access to tools that are useful for planning, postpartum planning, and for visit planning in ways that frame the healthcare as an ongoing resource for people, because we know that it is not that way, or not felt that way either by some. And so people go outside the system as much as they can and sometimes actively avoid it. And so we want to, again, be worthy of attendance. This third bullet's about including partners. The next, anti-racist care. And I put like components of that, like no negative assumptions, including, for example, about breastfeeding intent or not, and no discordant care. So like Black babies aren't going to be pink or whatever, like making sure that the information provided matches skin tone and other things. And we see that repeatedly, even, at UNC. So then holistic care, and we've been coding in the videos about like the depth and tailoring and making sure that things are talked through. Like you can't just hand someone a mood screening form or whatever and expect them to just put their full comprehensive truth on that. Like they need to know what you're going to do with that information and how it might help them. And they are also deciding, is it worth the risk? And so risk can be like emotional trauma, like sharing when things aren't going well. That doesn't feel good. It's nice. It's not nice to like revisit that. So that can be re-traumatizing. But if they think that that will lead to help for them, then people want that, of course. So go ahead.
Yeah. So Kristen, we have something in the chat because you asked me to show you. And maybe we could stop sharing this slide just so we have last look at people's faces before we sign off. So consideration of trauma-informed care on this slide as well.
Yeah, and could you share more about components of that? Because I think that that's a unifying theme for all this.
Sure. And just, understanding that certain approaches to our, the usual way that we provide office visits and care can be triggers for people that have had prior traumatic events in their life. So just simple things like the way you position yourself in the room and the way you ask questions and preface explanations about why you're asking those questions about, difficult topics.
Yeah, and we're coding things like eye level and proximity and openness, and it's interesting too because we also have active conversations about like reproductive coercion and IUDs only for Medicaid patients, and like we're almost so far away from like the trauma-informed holistic, hug and joy. But yes.
And I know we only have 5 minutes left, but I mean, something I've also heard from other times that you've presented this, I mean, I know that some of this really does feel aspirational, but I think other things you're finding are really, like you said, very concerning around not having access to food. And I think it's important in terms of the continuum, like you said, because there's a lot of assumption in a lot of places that you're getting all this information about your postpartum care and warning signs as you're being, and in the hospital. And so I think we have to realize that we all know that's not so not necessarily happening. So how do we think about information across these transitions of care? Which is why we can't just talk about it postpartum, but it's prenatal, it's around discharge, it's postpartum. It's something that I've heard, but I think y'all are uncovering what's so hard because like there's a staffing shortage and there's burnt out healthcare force. I mean, we're kind of in a clusterfluff at the moment in some ways because we have healthcare providers who are exhausted, patients, and it's kind of like how do we re-engineer the whole darn thing? I don't know.
And I think about burnout as moral injury. People are so in such unsustainable circumstances that it's hurting them deeply. So go ahead.
I wanted to say something. So for me, one of the things I think about as I go through the data is like, there's always a level of this would be nice to have. And this is like, if we think about it as a continuum, right? But I see one, that information question, like what people are willing to disclose based on their sense of safety as being kind of key, right? When you ask people things that you need to know to provide care, right? There's a range of things that they're not going to tell you if they don't feel that they can trust you and if they don't feel safe. That's one thing. And the other is we found several instances of people like testing systems and causing because they didn't trust, right? So like a couple of moms, not one mom, talked about testing the ankle monitors, just taking them off just to see what would happen because they weren't sure they could trust that the baby would be safe, right? And so when you talk about staffing and time and energy and effort and like what happens when people don't feel safe or they don't trust, it's like they do things to preserve their own safety that aren't necessary, that can cause more problems, right? They cause more work, let's put it that way.
Yeah, and so the Patient Safety Learning Lab, and we can send a link to it. So a lot of us, Sarah and I and Kimberly Harper, who you all know, were investigators on that. And so, I think the 4th trimester project is us in this movement, right? And so, different funding, different but overlapping team, and love to have follow-up through whatever mechanisms make sense. And like with your warning sign point, Sarah, so it's a Joint Commission requirement to educate on that. And so how that is achieved right now at North Carolina Women's Hospital is that upon admission to labor and delivery, people are given the AWON sheet. And then at discharge, it's a spiel, verbal, and then there's the ABS. And so that is not enough right? And so like, that's one concrete thing that, that's why we have those one pagers, for example, that have on New Mom Health, that have the warning signs, the concerning and the typical. And now we're building out the ABS and we're creating videos around it. So would love to chat if that's of interest together.
So with closing, I think, yeah, so I think as they're learning, and that's what we wanted, y'all were interested, we wanted to bring this so that you knew it was happening, you were starting to hear the things. And I think if this group is interested as we go forward next year and as the lab continues, there may be other opportunities for information sharing or interpretation, right? Or also what are the strategies within the context of what we can and can't do across the system. I did want to offer, this was a question last time we were together about that extended access to care for 1 year postpartum. So it is in the Senate budget. And this is awesome because it means it's a play. Well, if it's in the House budget, it would be supreme. I will let you know because you'll hear me yelling from wherever you are. And even if not, it still would go to conference committee and could be argued. Senator Bergen is a very conservative and a very powerful senator who has this as a cause. So I would think he would fight. So I just wanted to let you know, and on a positive, because obviously if we had more resources, it would help us provide more care longer. So that's just a little update on that for you all. The other little announcement is that there is going to be the National Maternal Health Symposium is going to be happening August 30th and 31st virtually, and it's free. And we'll share the link with you, as follow-up, but just in case anyone was interested, that's free and open to anyone who wants to attend. And again, virtual. And then our next is going to be around policy, August 27th. So maybe we'll have a good policy to talk about. I don't know, but we'll be also thinking about policy. And then as Kristen's noting that there's lots of presentations that are still happening. And I guess if they're ever recorded and we could share those links with everybody, we could do that too.
I mean, in the MHLIC symposium,
Oh, great.
A 1 hour workshop on SDOH, and Amelia has a Spark session on other work that she led on North Carolina Birth Journeys, who many of you may have helped spread the word about that a few months ago.
Yeah, it's actually going to be a really good symposium. Any parting thoughts or questions before y'all take off to the many things that are waiting for you? I think it's so amazing you made a whole hour for being together in this space.
Can I just share that I'm so sad and disappointed at the issues with providing appropriate interpreting and the idea of people not even getting food and things like that. And, I like to think that we are doing, that we do a lot better than that where I am. But, we have the resources of the hospital behind us and we can just get, we have our own in-house interpreter outpatient. We have our, inpatient in-house and interpreters and videos and phones and everything. But I know all the private practices in Greensboro don't have those at their fingertips. And that's just disappointing in this day.